Hi friends, good evening. I'm Dr. Ashutosh Gupta, and today we are going to talk about PGD A, right? So, meaning thereby that with this ART facility getting sort of an accepted all through the society, and then we are making the embryos in the lab, which we call as the in vitro fertilization, and then those embryos are being subjected to sub investigations depending upon the case scenario. So meaning thereby that we can have a PGDA, which is for aneuploidy, we can have a PGDM, which is for mutation, and PGDSR, which is for structural chromosomal translocations. So exclusively we are going to talk about PGDA. So we do come across with a lot of cases in which we've identified that the PGDA is telling us that it is an high mosaic, or probably we are having a lot of chromosomal abnormalities, meaning thereby that in one of the embryos we can have 4 5 chromosomal abnormalities and could be in high mosaic, and we can have a monosomy 7, we can have a monosomy 15, which for all practical purposes we have never heard of, right, in our clinical practice. So are they really true, or what is exactly the biological science behind it? So you try to understand the whole scenario that in normal spontaneous cycle, or as well as in an IVF cycle, the success rate is only 33%. So meaning thereby something around one third of the cycle, in a cycle we would have success rate by one third, right? So meaning thereby that all the pregnancies or the embryos, either spontaneous conceptions or whether we have made the embryos in the lab, they would get into a mitotic arrest, meaning thereby that is in the tune of 65%. हमारी जो सक्सेस रेट है वो एक तिहाई है. So what would happen for the remaining 65%? So they do have chromosomal abnormality in the background, and therefore they get into a mitotic arrest. So this is a common scenario. Like we make 12, like we have had 12 sort of an eggs getting picked up, and therefore we have made 12 embryos. But over the period of time, we identify okay, how many embryos would reach to that stage of a PGDA. So meaning thereby that 2 to 3, 4 embryos would get into a mitotic arrest. They will not multiply, and then they would get through the stages of a cleavage, then probably inner cell mass and then compaction. So meaning thereby that there would be a lot of clinical grading. So these embryos are being subjected to the microscope, and which we will identify the functional status, meaning thereby that probably we'll see how the embryos are multiplying and what is the stages of the cells, and then they would be frozen, and then they will be undergoing a PGDA, right? So let us first understand with the whole scenario. So in my clinical practice, we have looked around like a lot of this thing that we have had a high mosaic embryo, or we had multiple sort of chromosomal aberrations in the embryos, and even though we have got them transferred, and now I'm carrying a pregnancy. So this is a common scenario in which we do a microarray amniocentesis 16 weeks, and we do a microarray and we identify it to be normal. So the whole scenario is this, that PGDA being normal, PGDA being abnormal, and then the fetus at 16 weeks is we doing an amniocentesis, and then the baby is turning out to be genetically normal, leading to a normal baby. So let us first run through these slides, and then probably we'll talk about what is our take-home message. So the basic question is this, that PGDA shows high mosaic or multiple aneuploidies, right? So mostly are about to disappear. So we identify that it is a trophoectoderm biopsy which is being done, and therefore it is different from the inner cell mass which makes the baby. So self-correction is the norm, right? So trophoectoderm biopsy that we do can be done at 5 to 10 cells, and it gets into autocorrection. So is this PGDA false positive? So let us understand this from a very basic concept. So inner cell mass makes the baby, and trophoderm is the cells which gets biopsied, right? We do the biopsy from these cells, and so trophoderm might not be actual part of the baby which gets formed, right? So we can have an abnormal PGDA but a normal baby, right? So because then these are mitotic errors, these are not meiotic. So mitotic errors, they can happen. So PGDA is very good to look around for common aneuploidies, but not for segmental sort of a mitotic error. So because then the cells are multiplying, so they can lead up into a chaotic mitotic errors, and therefore leading to a lot of chromosomes. since the trophoblossom of the placenta is very permissible to the aneuploidy and therefore the baby survives, right? But the embryos basically they do have a lot of self-cleaning and adaptive mechanisms, right? So abnormal cells they die down, the normal cells they outgrow the abnormal cells, which is called as cell competition, and then then autophagy is there because then they get into a metabolic clearance, and then the cells abnormal cells they die down, right? And we do have a trisomy rescue or monosomy rescue by which the abnormal cells they get into an autocorrection, right? And there is a preferential growth. There is a preferential growth of the normal cells. Since we are making the embryos in vitro, so there is almost this has become a norm that we do a PGDA. PGDA meaning thereby that Down syndrome is one of the commonest thing aneuploidy that can really happen and which can survive the sort of a sieve or natural selection, and we can end up having a Down's baby if we don't do any further test into the antenatal period, right? So PGDA is justified and it is a valid sort of an investigations to be done basically to rule out common aneuploidies, right? Large monosomies and common aneuploidies. Once it turns out to be that chaotic thing, and then we identify a trophoderm is having monosomy 7 or monosomy of any of the chromosomes, or we can have some chromosomal abnormality involving 4 chromosomes in one of the trophoderm cells, which is theoretically not possible to happen. If there is a monosomy, if for all practical purposes, monosomy of any chromosome, had it been a case in that case, these embryos would not have gone to this stage of a blastocyst stage, like stage 16 or 16 cell stage or 32 stage, right? Like imagine a situation we have made 12 embryos, right? Out of that 4 5 6 they get into, they really don't divide, they don't multiply, they don't divide the cells, they don't divide, and then they get into a mitotic arrest very well. So meaning thereby that this PGDA comes at a stage 4 in which we identify that the baby have from a day 1, day 2, day 3, day 4 and day 5 they have gone to that stage in which it is a 16 cell or a 32 cell. So if a monosomy would have actual monosomy would have been there in the inner cell mass or into the fetus, it would have gone into a mitotic arrest. Secondly, this is since it is a mitotic error which is happening into and trophoderm cells, and therefore we can have this chaotic sort of this chromosomal aberration that usually comes up, right? So, meaning thereby that we take it with a pinch of salt. Success rate is only 1/3, right? You really cannot wait for those euploid things to happen, and so there are 4 5 6 mechanisms by which this baby clears this aneuploidy on its own, as I've explained it. So the normal cells, they outgrow the abnormal cells. The abnormal cell line, it dies down onto that particular point because of a lot of things across, and it is an autophagy, and therefore we identify, even though they survive, we identified that this could be a part of a confined placental mosaicism. So ट्रोफोटोडर्म जो सेल्स की हम बायोप्सी करते हैं वो एक्चुअली प्लेसेंटा बनाती है, जो कि जिसका एक एलिमेंट होता है इसको कन्फाइंड प्लेसेंटल मोजेसिज्म बोलते हैं. वी आर नॉट टेस्टिंग द इनर सेल मास विच एक्चुअली फॉर्म्स द फीटस. सो जो और ये जितनी भी एरर्स हम देखते हैं ये सब माइटोटिक एरर्स होती हैं, मीनिंग देयर बाय दैट देयर पैची. पैची मीनिंग देयर बाय एक या दो सेल, माइटोटिक मीनिंग देयर बाय कोई एक सेल डिवाइड हुआ और उस डिवाइड होने के दौरान में ऐसा हुआ कि क्रोमोसोमल कोई एबनॉर्मलिटी उसमें हुई और हमने कैप्चर कर लिया, राइट? बट सिंस इट इज माइटोटिक, सो वो उसी सेल में ही रहेगा, या वो सेल लाइन इधर वो डाई डाउन और प्रोबेबली ऑटोफेगी से भी वो खत्म हो जाएगी, राइट? सो देयर आर लॉट ऑफ mechanisms by which all those abnormal cells they die down on its own, right? So whether we identify that the PGDA is a false positive, the answer is outrightly no. But probably we can do it for a common aneuploidies or for sort of an whole chromosome monosomy, right? Which I also don't believe, because अगर मोनोसोमी अगर होता है किसी भी जाइगोट में तो वो अरेस्ट में पहले ही चला जाएगा, वो पीजीडीए वाली स्टेज तक जा ही नहीं पाएगा, right? And any which ways, we have had a lot of experience by having these high mosaics and low mosaics and multiple sort of chromosomal abnormalities, embryos being getting transferred and surviving. वो सिर्फ 1/3 survive करेंगे. So this is the background, okay? So make it a very sort of an important point, and take home message is this, that जो भी एम्ब्रियो जो भी पीजीडी एम्ब्रियोज होते हैं वो ट्रांसफर कराते हैं, सक्सेस रेट सिर्फ 1/3 की होती है, And then also, if we would have done an amniocentesis, what we've identified is that the chromosomal complement of the baby at 16 weeks is absolutely normal, and we can have a normal baby. So it is a common scenario to see that the PGDA is abnormal, outrightly abnormal. Amniocentesis and genetic makeup of the baby, looking around for all the chromosomes of the baby, is absolutely normal, and we can have a normal baby. So this is a common scenario, right? Thank you very much for your patience.